Hello, this is Carly Moore for the Pulmonary patient assessment video. I'd always start by entering the room, washing my hands, and introducing myself as a PA student. For the first part of the video, we're just going to have the patient cross their arms over their chest and then just take a couple deep breaths, and we're going to watch the rise and fall of the chest, noting the rate, rhythm, any deformities, any intercostal retractions, or accessory muscle use. And then we're just gonna I'm gonna kneel so you can see what I'm doing, but I'm just gonna palpate the posterior and lateral sides of the chest. And then I'm going to check for respiratory expansion by having my thumbs touch here, and then take a big deep breath, and then they should separate and come back together. Next, I'm going to percuss. And then laterally as well. Okay. And then for diaphragmatic excursion, what we would do is you don't actually have to do it, but you would have the patient take a big deep breath, exhale out, and then hold their breath. And on the left scapular line, you would percuss all the way down until the sound changed from resonant to dull. And at that line, you would mark it, and that's where the diaphragm should be. I'm going to move on to the voice transmission test. Well, actually, I think I'm just going to auscultate normally first. Okay, anytime you feel my stethoscope, will you just take a deep breath? Okay, and then whenever you feel my stethoscope, say 99.
99, 99, 99, 99, 99, 99.
So for a normal test, for tactile ephrematitis, we would want the voice to sound kind of muffled and indistinct. An abnormal test, it would sound like a very loud and clear voice. So we're going to move on to whispered pectoriloquy now. So we're going to say, can you say 99, but just whisper it this time?
99, 99, 99, 99, 99, 99.
And then that same rule applies. So normal test, it should sound muffled and indistinct. And then an abnormal test, it would sound loud and clear. Now for the egophony test, which is another transmitted voice sound test, we're going to have, if you could say E-E-E anytime you hear or feel my stethoscope touch.
E-E-E, 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 E-E-E.
Okay. And then for that one, the E's would sound more like A's or A's if that was an abnormal test. Okay, I'm going to have you lay down now. I'm going to change the position of my camera so that way you can see. Okay, so, oopsies, so sorry. Okay. Same thing we did for the posterior chest, we're just going to do anteriorly. So just going to inspect the rise and fall of the chest, noting the rate, rhythm, any accessory muscle use, retractions. Also going to take time to look at the trachea, make sure it's midline. So will you take a big deep breath for me? Okay, looks good. Palpating the chest here too, just noting any tenderness. And then laterally as well. Okay. And then we're gonna test respiratory expansion the same way that we did posteriorly. So hands together like this. Take a big deep breath. Okay. Okay, and your thumbs should spread apart and then come back together. Let me think. I'm gonna go ahead and percuss here too. So in the same ladder position that we did posteriorly. And on the sides as well. Okay. And then whenever you feel my hand, touch, say 99.
99, 99, 99, 99, 99, 99.
Okay. I'm gonna auscultate here as well, using the same type of ladder motion that we did on the back. And then just with an open mouth, if you'll just breathe when you feel me touch. Okay. And I'm trying to think if I got everything. Okay, I think that concludes the pulmonary physical exam.